Dr. Nasser is my is my friend, coursemate from Dhaka Medical College, a brilliant academician, a brilliant track record everywhere. So currently he's working in Iowa Clinic as interventional cardiologist, and he's also the adjunct professor at University of Iowa, and he's the medical director of Cath Lab and Structural Heart Program. So Nasser, you're most welcome to deliver your lecture on TAVR or open heart, how to choose.
Thank you so much, Tawfiq, for the very generous introduction. And I'd like to thank the BSCI and the entire team, including Professor Azam, for inviting me. And this is a great opportunity and honor for me to be here. And I really applaud the wonderful initiative you all have taken. This is really wonderful. We all are learning. I mean, the sessions are absolutely wonderful. So I'm just going to start sharing my slides, and I'm going to keep my talk in 15 minutes. Not see my screen yet, can you?
Yes.
Yeah, we can see your screen. Yeah, you just need to make it full screen.
All right, is that good? Can you see it now?
Yes.
Perfect.
Yes.
Okay,
Perfect.
Okay, so we are going to talk about TAVI or TAVR, and Dr. Parekh is the speaker next after me, and he's going to show a case. I'm going to sort of try to set the stage for him and essentially talk about a little bit about the journey of TAVI, and then the main question is TAVI right for your patient? And let us look at some scenarios. Is TAVI appropriate for a 55-year-old patient with a bicuspid aortic valve? Is it appropriate for an 85-year-old patient with COPD with previous bypass surgery? Or maybe a patient who's 70-year-old with a porcelain aorta? Or maybe a 75-year-old patient with severe bilateral femoral artery stenosis with large calcium in the annulus of the aortic root? So after the talk, I hope we will all be able to answer these questions. So as we all know, the aortic stenosis progresses, and we are now leaning towards more by classifying the disease. The stage A is when you're at risk. Stage B is mild to moderate. Stage C is when the disease is severe but there is no symptom, and D is severe with symptoms, and obviously we treat the symptomatic severe aortic stenosis, and asymptomatic if their EF is less than 50%. So aortic stenosis is a disease that progresses very slowly, and there's a long latent period. But when the symptoms start, the cascade starts, the patients start going downhill very rapidly, and you have the symptoms of the SAD, the syncope, angina, and the dyspnea. When they have a heart failure, their survival is only 2 years. So for the fellows, the question would be, after onset of symptoms, severe aortic stenosis patients have following survival rate in 2 years would be 80%, 70%, 60%, 50%. For the sake of time, I'm going to answer this myself. So and the answer is 50%, meaning like if you have symptoms with severe aortic stenosis, the survival rate is 50% in 2 years and only 20% in 5 years. So in 5 years, 80% of these patients will just die if you do not treat them. So what is severe aortic stenosis? The aortic area is less than 1, the mean gradient is more than 40, and the velocity is more than 4, and any one of them can meet the criteria. So traditionally, surgical treatment has been the standard of care that evolved over the 50 years and has done a wonderful job. The surgeons have done absolutely wonderful job for the last 15 years. But there were certain problems with surgery. What are the problems? A lot of these patients, the surgeons thought were high risk and would not treat them for obvious reasons. They could have a history of stroke, old age, they could be frail, they could have a heavily calcified, the porcelain aorta we talked about, which makes the surgery very high risk. They can have bad COPD, increasing the surgical risk. They could have past radiation to the chest. They could have past open heart surgeries. And all these factors increase the surgical risk. And so the surgeons were not treating these aortic stenosis patients, and they were just left untreated, living miserably and eventually dying. So we thought of the balloon valvuloplasty several years ago. But the problem with the balloon valvuloplasty is that although you see initial symptomatic improvement, the complication rate is very high. The recurrence rate is very high, and the mortality is up to 50% when you do a follow-up for 6 months. So this is how the journey of TAVR started in France by Dr. Alain Cribier. In 2002, actually, he started in a cath lab in a very sick 57-year-old patient. And then it kind of evolved in Europe. A lot of cases were done in Germany and then kind of matured in the United States. And USA, as usual, was one of the last countries to adopt it. So although the first case was done in 2002, the first FDA approval came in 2011. So it took almost 10 years just to get the first TAVR approval in a regular setup outside of research. So, but with time, we have seen, we have gathered experience, we are more selective with our cases. We have improved our procedure skills. The devices are improved and also the sheaths are smaller. So the complication rates are lower. Right now, there are three FDA approved valves. The two commonly used, one is the balloon expandable, the other one is the self-expandable. So going back to the journey, the journey started with the PARTNER 1 trial, which was approved for high-risk surgical patients in 2012. And then became the PARTNER 2 trial, which was for the intermediate risk patients that was approved in 2016. And the landmark PARTNER 3 trial, which was done in low-risk surgical patients with excellent results, which I'll show you in a minute, that was approved in 2019. So the most important thing is the last line, as you can see. Over the years, what happened was not only the TAVR valve number increased, but the surgical valve also increased. So there was a 94% growth of all valve surgical plus TAVI from 2012 to 2019, because now patients are now on our radar. So we are just identifying these patients, watching them, either sending them to TAVI, or some of them, a lot of them are going for open heart surgery. So the overall, we are treating them more, we're doing a better job. So, and also with time, there was a significant increase in the mortality. In 2012, the in-hospital mortality was 5.7%. It fell to only 1.3% in 2019. And the 30-day mortality also decreased from 7.5 to 2.5%. The hospital stay, as you can see in the beginning, were 7 days, but now we are sending everybody home just the next day. So this is a great thing. So the PARTNER 1, PARTNER 2, PARTNER 3 trials are on the balloon expandable valves, and the TAVI was on the self-expandable valves. I'm not going to go into the details for the sake of time, but I just want to touch some base on the findings of the PARTNER 3 trial. So it was obviously done in the low-risk patients, and TAVI was superior to open heart in preventing death, stroke, or rehospitalization in 1 year. And this benefit was sustained for 2 years. It was also associated with lower incidence of stroke and AFib and shorter hospital length, and there was improved quality of life for the patients. And although there was some numerical increase in the number of pacemakers, but this was not statistically significant. So this was a recent meta-analysis done on the TAVI and the PARTNER 1, PARTNER 2, and PARTNER 3 trial. The left side of the screen favors TAVI and the right side of the screen favors open heart, and you can clearly see the bias towards the TAVI. So as a result of that, you can see, this is the US registry, the number of TAVI surpassed the surgical valve in 2016, and that was only surgical valve. But if you combine the surgical valve with CABG, that also was surpassed by TAVI in 2019. So you can see the graph, how it's growing up, and it's not going to stop, I can tell you that. And this is the worldwide picture. The blue line is EU, the red is the United States, and the top black dark one is rest of the world. And you can see the worldwide trend of TAVI growing. So it is not the future, it is the present. It has come to countries, developing countries like in India, it will come to Bangladesh, and it's just a matter of time. We just have to understand the reality. And back in even 2016, according to the TVT, 65 countries were doing it, and this is 5-year-old data. So more and more countries are getting into TAVI. So that brings us to the most important question: does it mean that TAVI is right for every patient? And the answer is absolutely no. Why? The first problem, the durability. We have good data on the surgical valves. We know they last at least 10 years. But we do not have a long data on the TAVI valves. We know they do good for at least 5 years, but beyond that, we still do not have a very strong data. That's problem number one. Problem number two, all the data that have shown the good results are all on transfemoral access. If you have blockages, because these are big sheets, so you have to make sure you have good access sites. And if you do not have good transfemoral access, the other alternative accesses do not have as good outcome. And that could be a selection bias because those people can be sicker. But the bottom line is the good results are with transfemoral access. The third problem, if you have a calcium in the annulus, that could rupture. This calcium can rupture when you're expanding the valve, and that can be a disaster on the cath table. Not only that, even if you deploy the valve may not seat well because of the calcium, and you can have perivalvular leak. And perivalvular leak is something that increases mortality. And in the initial studies, there were 10 to 15% people who had moderate to severe perivalvular leak. Obviously, that's not a good thing to have. Bicuspid valve, it's a whole different animal. Younger people have bicuspid valve, a lot of calcium. The structure of the aorta is different. It's kind of elliptical versus roundish. So the larger trials excluded the bicuspid valves. So there are some registry data in favor of that, but the data is still not robust. And of course, when you're deploying a TAVI, you can occlude the coronary. So you have to be very careful about that. And not only that, you have deployed a valve, and in 5 years from now, the patient comes with an MI in the middle of the night, you're doing a primary PCI. It could be a huge challenge for us to cannulate that coronary through that TAVI valve. So you have to keep all these things in mind, especially if you're putting a TAVI valve in a young patient. And finally, the need of pacemaker. So depending on the data, it's 10 to 15% still the need. So it has kind of come down to 10% around, but still 10% people will end up getting a pacemaker if you put a TAVI valve. So that brings us to the whole thing of how do you decide who's going to go for a TAVI? And that's brought the surgeons and the cardiologists together. We work as a team. We spend hours. To put a valve, it takes 45 minutes, an hour. But we spend hour and hour deciding as a group what is the right thing for the patient. And that's the most important message I want to convey to you today. So before you start a TAVI program. So you have to involve the surgeon. You have to have the interventional cardiologist, the imaging cardiologist, sometimes the radiologist, the nursing team, anesthesiologist, and a valve coordinator in the US system who coordinates all the steps. So the steps you start are with, of course, with an echo. You have a coronary angiogram. You have a TAVR CT to see the annulus, to see the aorta, to see the access. It's a special TAVR CT is done. You want the surgical risk, so you want to do the carotid duplex, the pulmonary function test. You have to have the STS score, the frailty, and the eyeball test, where you kind of see the patient and know this patient is going to be high risk or low risk. So after the risk assessment, you group together, you review the echo, review the angiogram, review the CT, and then you decide, okay, this patient is going for surgery, or this patient is going for TAVI, or maybe this patient is not going for anything. This patient is too sick. We have just done a palliative care medical management. And that's absolutely fine. And that's the decision you have to take. Otherwise, the patient will die on your chair. So the ACC guideline has actually made it quite simple for us. That came out in December 2020. So it's really not the surgical risk based now, more it's age based. If I just make it short, less than 65, age less than 65, open heart is recommended. It's class 1 indication. More than 80, TAVI is recommended over SAVR, over open heart. If you're between 65 to 80, that's the time you have to group together. I mean, you have to group together for every case, but you have to spend more time and also make a shared decision with the patient. The patient has to understand the durability and the problems with TAVI and the problems with surgery and the advantages of both procedures. Then along with the patient, you make a decision and you decide what's going to be the best for the patient. So a quick recap, the things that would favor TAVI would be if you're doing just a valve, if there's a porcelain aorta, increased surgical risk, TAVI is preferable. Chest radiation deformity, previous sternotomy, severe lung disease, frailty, and small annulus. If you have a small annulus, the TAVI valve expands more than the surgical valve, so it's preferable. On the other hand, you would send the patient for surgery if they have multivessel disease, they need a bypass surgery. They have mitral valve disease, they need a double valve surgery. They have a large aneurysm, they will have to have that fixed. If they have low coronary height or small sinus of Valsalva, you can obstruct the coronaries, so they should preferably go for open heart. If they have a large annular calcium, poor femoral access, or if they're a young patient with bicuspid valve, open heart is favorable. So I guess I'm still within the 15 minutes, that's great. So I guess that take-home message is TAVI is here to stay, and it is not the future, it is present. It is gonna grow, it is gonna come to all developing countries. We just have to prepare ourselves. But the most important thing is to understand, and it's not for everyone. The patient selection is crucial, and it brought us together, surgeons and cardiologists together, to form the heart team. And because it's not about the cardiologists, it's not about the surgeons, at the end of the day, it's all about our patients. Thank you.
Thank you, Dr. Nasser Khan. Absolutely brilliant presentation. Whilst we are waiting for questions from the audience, I would like to ask you, what's your approach towards a patient who had a previous tissue AVR. So if the patient is low risk and needs a redo valve surgery, would you prefer TAVI or would you go for surgical AVR?
Great question, Dr. Shakil Farid. Again, these decisions we always take as a group. Like I said, the heart team will take the decision. So valve in valve TAVI, as you know, I mean, as a surgeon, you probably would not want to, I mean, there's a higher risk of surgery for a second, sternotomy. So probably you're going to say, maybe, if the patient has no other problems, try TAVI, like valve in valve TAVI. There are certain challenges in valve in valve TAVI. You have increased chance of occluding the coronaries. So you have to make sure that you're not going to occlude the coronaries with the first valve, the leaflets come out and, occludes the coronaries. So one thing is, the basilica procedure. I'm not going to go into that. The other thing is the patient prosthesis mismatch. So you put the TAVI valve within the surgical valve, and then sometimes we have seen the gradient even increase on the cath table, not only later, but on the even the cath table. So in 2015, the first fracking was done. So what we do is we put a TAVI valve within the surgical valve, then we take a non-compliant balloon, we inflate it high pressure, and we crack the ring of the first valve. So this is a very tense moment in the cath lab. You're cracking the surgical valve, but you can sometimes hear the pop. But once you do that, you release the pressure and the outcome is really good. The only problem is that not all surgical valves, absolutely, I'm talking about bioprosthetics, the mechanical valves are not frackable. So not even all bioprosthetic valves are not frackable. One of them is, you probably know, trifecta. So I guess as a surgeon, my request to all the surgeons would be now to be more mindful when putting a bioprosthetic valve, like to be selective in what kind of valve we are putting in, because in future, if the question comes for a valve in valve TAVI, then we can easily frack it and fix it.
Yeah, thank you, Dr. Nasser. I think you have raised a very important thing. I just wanted to re-emphasize about the trifecta. Trifecta use has been stopped in UK because of the poor results. So this is perhaps something the Bangladeshi cardiologists and cardiac surgeons need to know. And on that note, there's a Resilia valve, which is a bit expensive, but it's easily, you can easily actually break the hinges, and it's quite easy to do valve in valve TAVI. A lot of our younger patients are actually preferring that. Thank you. Any questions from the audience?
Shakil? Dr. Shakil? Yes, I
have a question to Dr. Nasser.
Yeah,
thank you.
It's a question to both of you, yourself and Dr. Nasser. In this subcontinent, a quite sizable number of patients have a rheumatic background for aortic stenosis, and where there is a lot of commissural fusion. So what are the feasibilities of TAVI in a patient of a aortic valve with a rheumatic background, number one? And number two is, in a patient with bicuspid aortic valve, there is a subsequent deformity of the aorta. The surgeons, they do the Bentals and other things. But if we address this group of patients with a bicuspid aortic valve with a TAVR, what will be the subsequent need of any surgery in the long run in this group of patients?
Excellent
that's
questions.
A great question.
Yeah, they're great questions, Professor Khalid Mohsin. So first of all, in both cases, actually, TAVI is the bottom line is, in both cases, TAVI is not the number one choice. In rheumatic valvular disease, probably the patient, probably open heart is preferable because the data is limited, but the majority of the studies were done in the Western world where the rheumatic valve disease were mostly not included. So we don't have a strong data, but from what we have learned is that in rheumatic valvular disease, most likely open heart will be preferable. I'd like to know Dr. Shakil for his opinion on that as well. And also similarly for bicuspid valve, the similar thing, especially for a young bicuspid patients, the patient should preferably go for open heart. There are some registry data, and we have done bicuspid valves in TAVI patients, but that is the situation and only when the surgery would be so high risk that, TAVI would be preferable. But these are absolutely great points.
Thank you, Dr.
I totally agree with you. I think just, sorry, Pradeep bhai, just one point I wanted to make. The thing Nasser has said, in bicuspid valve, we see the annulus is quite big, and quite often it is 29 and above. And we know that TAVI valves, conventional TAVI valves, don't go above 27. So that's why bicuspid valve, first problem is the dilated annulus. Second problem is the shape of the annulus, which is more oval. So if I'm starting off a TAVI program in any country, I wouldn't touch that patients to start with. Those patients we need to select who are elderly and not suitable for surgery. They have a bicuspid valve. You just accept the risk and do a TAVI to them. Thank you.
Hi, this is Dr. Maulik Parekh. I'm the next speaker. So I'd like to share my 2 bits on these 2 questions, one on the rheumatic heart disease and one on the bicuspid valves. So we are getting a lot of patients in, I practice in India as a structural interventionist, and there's a lot of patients who are, so we all know that mitral valve is 5 times more commonly affected in rheumatic heart disease compared to aortic valve. But up to 30 to 40% of the patients will have both valve affection. Aortic will progress very slowly, mitral will progress very fast. So we have, I do at least 1 TAVI in 6 weeks or 7 weeks on a patient who has a tissue or a metallic mitral valve, has undergone 1 or 2 previous mitral valve surgeries because of rheumatic heart disease. And now they're in their 60s, 65, 67, 68. And now the originally affected aortic valve, rheumatic affection has progressed to severe. But these patients are intermediate to high risk for surgery because they already have a metallic or a tissue valve in the mitral position. So that is one subset. They're very peculiar to our part of the world. I'm sure Western world will not see this type of patients.
I think, Dr. Maulik, can I just interject? Yeah. You have actually made a very important point. I'm giving the answer now. So imagine this is the valve annulus. As Dr. Nasser Khan has shown that if you have a very calcified aorta annulus, it's dangerous because you can rupture. On the other hand, if you have no calcium at all, you cannot put a TAVI valve in.
Yes.
So one of the problems with rheumatic valve is you see less calcification, so the anchoring is less. However, if there's a mitral valve in place, you got sort of a rigid structure already in one part of the annulus, and you have some sort of rigidity in rest of the annulus. So those cases are actually quite good for a TAVI, especially when the risk is high. So that is a specific subset where I would actually advocate TAVI instead of surgical AVR.
Another thing, in case of rheumatic valve, actually it has happened in the less than 40 years of age.
Yeah.
Yes.
Yeah.
And the rheumatic fever is a continuous inflammatory process. If you still it in the, I know there are some study, few valve is placed in rheumatic position, but the condition is not good in India. So for this reason, still now it is in investigation stage, because the inflammation procedure is continuous even in the valve, and very soon they become thrombosed and the valve become damaged. I have some question to the Dr. Nasser Khan, because I have started the TAVI program in our National Institute recently. You know, the calcification is needed for the anchor of the valve. We only exclude the cases which are the calcification in the outflow tract, not in the annulus. One thing. Another thing, do you have any experience of the my valve is made in India, because they have the very low incidence of pacemaker implantation after the TAVR?
So can I, I'm sorry to interrupt.
Okay.
Can I
you are making a second
couple
point
of cases, because all this alveolar calcification, bicuspid aortic valve, and TAVI and rheumatic, they're all part of my presentation. So, and can we have the discussion? Okay. It will have more.
Yeah, so we can have discussion after your. So shall we move on? Shall we move on to the next presentation then?
Yes.
The questions are each one of this is a case in my presentation. So.
Dr. Pradeep, can you hear me?
Yes.
I think we should move on to the next
Before
speaker.
going to Parekh presentation, you just take a quick review from Professor G.M. Farooq sir and also Masudjia Chaudhary for a quick review for 1 minute.
Yes, sir. Sir Farooq sir. Salaam sir. Can you have some comments, sir?
I think you need to unmute your mic, Professor Farooq.
Okay. Yes.
Thank you.
Can you hear me now?
Yes, sir. Clear and audible, sir.
Yes, I have been hearing all of you very silently. Basically, I am a silent person, you know. So that's what the habit is now reflected here. The review is okay. I think the only thing I would like to know, in India, I don't know what is in USA. What I want to know in India, how much is the cost for this one? I will ask this question to Sai Satish, what is the cost for this whole procedure?
Mitra clip. What's the device, sir?
Metal clip.
The Mitra clip in India costs, the clip to the patient is 25 lakh rupees. And since the hospital stay is so short, they stay hardly for 2 days, most of the patients. So we wrap up around under 30 lakh Indian rupees, 28, 29 usually. But majority of the cost is the 25 lakhs of the clip.
And the second point is what is the oldest patient where you put this clip?
My oldest patient is 93. And
no, I'm saying actually my question is, what are the first case which you made, put the clip?
I did my first clip 3 years back on a 91-year-old lady. And today she is 94, she's still asymptomatic. Exactly. The important thing is to get a really good MR reduction. And then they just do really well year after year. Dr. Khan, you'll pitch in?
She doesn't have any other risk factor like blood, hypertension, diabetes, nothing?
No, so I always say, to reach 90, you need a good heart, good lungs, good liver, good kidneys. Once they reach 90 and they have one of these things like an infection or a hip fracture, but if you fix them, they do really well. She was only a hypertension.
Thank you very much. Okay, Pradeep, go for the next case. Yes.
Thank you very much.